Welcome to this video on the outpatient management of community-acquired pneumonia, or CAP. We will cover evidence-based clinical pathways, empiric regimens, and guideline syntheses for adult outpatients. Please note that this is a study guide and not for clinical management decisions. Community-acquired pneumonia, or CAP, is an infection of the pulmonary parenchyma acquired outside the hospital. Hospital-acquired pneumonia, HAP, is acquired 48 hours or more after hospital admission. The term healthcare-associated pneumonia, HKP, is now retired, and these patients are treated as CAP. Triage begins with filtering out clinical instability, requiring the ICU, and psychosocial or functional barriers that necessitate inpatient care. Next, check for hypoxia. Finally, use the Pneumonia Severity Index, PSI, to determine the site of care. PSI classes 1 and 2 are suitable for outpatient treatment. A mandatory diagnostic baseline for CAP requires a clinically compatible syndrome, plus an infiltrate demonstrated on chest imaging. Routine microbiologic testing is generally not needed for mild outpatient CAP, given the high success of empiric therapy. Exceptions include high local activity of influenza or SARS-CoV-2, or high suspicion for Legionella or CA-MRSA. The core targets for all CAP patients are Staphylococcus pneumoniae, Haemophilus influenzae, and atypical pathogens. For comorbid, older, or smoking patients, expanded targets include beta-lactamase-producing Haemophilus influenzae and Moraxella catarrhalis. Structural lung disease adds Enterobacterales like E. coli and Klebsiella species to the list. The treatment philosophy centers on a beta-lactam backbone, such as high-dose amoxicillin, primarily targeting S. pneumoniae. An atypical add-on, like a macrolide or doxycycline, targets atypical pathogens. Combination therapy is preferred for potential morbidity benefit and low risk. The up-to-date approach differs from the 2019 guidelines. For healthy outpatients, up-to-date recommends amoxicillin plus macrolide or doxycycline, whereas the 2019 guidelines recommend macrolide monotherapy. For comorbid or older patients, up-to-date explicitly prefers amoxicillin clavulanate with an atypical, due to its reliable activity and favorable side effect profile. Pathway A is for the healthy outpatient, defined as less than 65, with no major comorbidities or recent antibiotic use. The primary regimen is high-dose amoxicillin plus a macrolide or doxycycline. For mild penicillin allergy, cefpodoxime plus a macrolide or doxycycline is the alternative. Pathway B is for the comorbid or older outpatient, defined as 65 or older, with major comorbidities, smoking history, or recent antibiotic use. The primary regimen is amoxicillin clavulanate plus a macrolide or doxycycline. For mild penicillin allergy, cefpodoxime or cefuroxime plus an atypical is the alternative. For severe IgE-mediated reactions to penicillin, respiratory fluoroquinolones like levofloxacin or moxifloxacin are alternatives. However, their use is discouraged in ambulatory patients due to severe adverse effects and the risk of promoting resistance. If SARS-CoV-2 or influenza is identified in a CAP patient, administer antivirals if standard criteria are met. The rule for antibiotics is that the threshold to stop is higher than the threshold to start. Discontinue empiric antibiotics only with suspicion for a concurrent bacterial process, indicated by markers like consolidation on imaging or normal WBC count. The standard duration of therapy is 3 to 4 days. Antibiotics should only be stopped when the patient has been afebrile for at least 48 hours and is clinically stable. Do not extend the course simply because symptoms like cough persist. Shorter courses reduce adverse events. Clinical resolution of most symptoms occurs within 14 days, though chest infiltrates may take 30 days or more to resolve. Routine follow-up chest imaging is not needed for clinically responding patients. A mandatory clinical check-in 24 to 48 hours after treatment initiation is recommended to ensure no deterioration. The triage rules require admission if O2 saturation is below 92%, high PSI score, or psychosocial barriers exist. For the healthy outpatient, the primary regimen is amoxicillin plus an atypical. For the high-risk outpatient, it is amoxicillin clavulanate plus an atypical. Duration is 3 to 4 days, stopping when afebrile for 48 hours. This content is supplementary information for medical students and should be used with official course materials. While due diligence was exercised, the content may become outdated quickly.